Hi, everybody. Nice to have you here tonight. Dr. Briggs, the current chair of the ASGO, is going to introduce the speakers tonight.
Good evening, everyone. Thank you and welcome to our ASGO webinar. It's my pleasure to introduce the team today who will be presenting a panel, starting off with our moderator and presenter, Dr. Anaïs Rameau. She's an associate professor of otolaryngology and chief of dysphagia and director of new technologies at the Weill Cornell Medical College. She's the first otolaryngologist to have received the prestigious Paul Eason Award from the National Institute of Aging. She's an internationally recognized expert in AI in the field of otolaryngology. Next, we have Dr. Matthew L. Bush, who is a professor and chair of the Department of Otolaryngology at the University of Kentucky. He's a neurologist and an expert in health equity research, focusing on rural populations. And finally, we have Dr. Neel Bhatt, who's a laryngologist and assistant professor in the Department of Otolaryngology at the University of Washington. His research is focused on understanding the neuromuscular changes in the age of larynx. Thank you so much, and we look forward to your presentation.
Thank you so much, Dr. Briggs. I will go ahead and share my slides. So tonight I will be talking about geriatric deglutology innovations in the era of digital health. These are my disclosures. And first, what is gerontechnology, which is the topic that we're talking about tonight? So gerontechnology is really a multidisciplinary field that has brought many different people together since the 1980s. It deals with basically the challenge of having societies that are aging, and how do we support older adults in our modern environment by leveraging technology. And it goes beyond healthcare. So the focus of gerontechnology is not just the health of older adults, but it's also their mental, their social, economic, and cultural environments, and how to improve them and make them more ergonomic for older adults. Now, I am focusing on swallowing dysfunction in older adults because older adults have a lot more swallowing dysfunction than other age groups. Besides just the process of aging, there are many pathologies that are associated with older age that can also lead to swallowing dysfunctions. And we know that pneumonia is the old man's friend from William Alsler, and that the prevalence of aspiration and aspiration pneumonia increases as we get older and becomes especially prevalent in the acute care setting and also in nursing homes. So much so that the European Society for Swallowing Disorders suggested back in 2016 to make oropharyngeal dysphagia part of the geriatric syndrome. Now, we're going to shift gear and really focus more on digital health here and swallowing. And just like other fields of medicine, we saw an explosion of interest in digital health applications in swallowing care during COVID-19 because we had to self-isolate, and people started to think about ways to monitor people remotely. And there's also the recognition that dysphagia expertise is actually very limited. There are vast regions within the United States where you can't really find speech and language pathologists or MDs that have expertise in swallowing. And so, and there is also the additional complexity in swallowing care that a lot of the swallowing evaluation currently require instrumental testing that are not widely available. So as a result, there's been a lot of interest in thinking about ways to find digital markers of swallowing dysfunction that don't require a clinic visit. And one of the obvious one has been voice. And we coined actually the term audiomics to really describe this interdisciplinary field of audio analysis to find acoustic biomarkers of health and disease. And it seems simple, but actually using voice to detect swallowing dysfunction or other pathologies is actually really complicated because although in laryngology, we have been listening to voices and we've been collecting voices for a long time, this is not really true in the rest of the medical enterprise. And so there are a lot of things to do, like creating standards for data acquisition, interoperability, defining AI readiness, and also really understanding the ethical basis of this work. And so several of us are involved with this big grant from the NIH Common Fund called Bridge to AI, and we're specifically looking at voice as a biomarker of health. And so there have been a lot of efforts in trying to use voice as a biomarker of swallowing dysfunction, but human judges are actually not very reliable, and there hasn't been really demonstrated tool where humans can actually use their ear to detect swallowing dysfunction. And so more recently, technologists have had an interest in using AI to see if AI could help us detect some changes in the voice related to swallowing dysfunction. And these are only two of the now 6 publications out there that report on AI applications to voice. And so the very typical way that this would be done is that you'd be collecting data on patients who have gold standard swallowing evaluations and are known to have swallowing dysfunction and or normal swallowing. And you want to combine that with demographic information. You want to have a specific protocol for data collection. And then you want to run this collected data through an algorithm that then will help you classify voice as normal or associated with swallowing dysfunction. Oftentimes, you'll end up having a curve very similar to this, which is a receiver operating curve, and it will determine whether you're close to having a diagnostic test, but oftentimes these tools are overrated. So don't really believe the hype and just be critical when you're reading some of these papers. This is some work we've done in the lab at University of Cincinnati with the late Sid Khosla, where we try to have a controlled setting to see if we could find a biomarker of swallowing dysfunction, and using a canine model. And we actually did find one. We did find that the high harmonics tend to be modeled when there's material on the vocal folds. So currently, we've collected voices of patients undergoing swallowing evaluation, and we're trying to see if this biomarker we found in the lab also translates in humans. But there are other attempts in using sounds for assessment of swallowing dysfunction. Again, the idea is to provide these tools for remote monitoring and potentially finding ways to look at patients in their day-to-day lives. And when we're thinking about older adults, oftentimes when they come to our clinics and their performance during their swallow test or even their vital signs doesn't really reflect what happens on a day-to-day at home. So some of these tools are trying to overcome these limitations. So there are a lot of efforts now to also use contact microphones and cervical auscultation to see if patients may have swallowing dysfunction. There's also a lot of interesting efforts in Japan, where we have the oldest societies in the world, and where swallowing is actually extremely burdensome problem for the healthcare system. And there's been an effort in actually using images of the anterior neck to be able to detect swallowing dysfunction and sarcopenic dysphagia specifically. So that's exciting. Also in Japan, where dentists are involved in the care of people with swallowing dysfunction, there's been an interest in using Panorex images to be able to detect swallowing dysfunction risk, with the assumption that the farther the distance between the hyoid and the mandible, then the higher the risk of swallowing dysfunction, because probably the laryngohyoid elevation is limited. There's been also very interesting efforts with wearables, including at Northwestern University, where this wearable device measures mechanoacoustic changes and has been able to really distinguish breathing sounds from swallowing sound and finding ways to see abnormal patterns between the two. Now shifting gears and looking more at prognostics, a lot of older adults, when they come to the hospital, will be at higher risk of having aspiration pneumonia, but we don't necessarily understand what the risk factors are beyond head and neck cancer or dementia. And so this team here from Austria has really created an amazing algorithm that was not only validated on retrospective data, but also on prospective data that is able to actually assign swallowing disorder risk to patients who are admitted, which allows for early intervention and prevention of development of aspiration pneumonia in the hospital. Among other clinical decision support tools, there's been also an interest in applying AI to assessment of modified barium swallows, which are very complex. And although there are a lot of different standardized tools for assessing them, the problem is that swallowing is still a very fast and rapid event. And so maybe AI can help us really pick up on subtle aspects of swallowing and also make the process of analyzing a modified barium swallow easier on humans. This is another interesting effort in developing AI for assessment of fees for flexible endoscopic evaluation of swallowing, which again has its own complexities. And even though there are validated tools, there are not many specialists who can really rigorously apply those tools. And so this tool that was developed also in Japan is looking at the safety and the efficiency of swallowing and actually surpassed human raters. Now more in the area of rehabilitation, we see some really interesting developments with wearables for swallowing. And that's not just for biofeedback during exercises, but also for monitoring how much patients are doing their exercises and whether there are changes in their swallowing function over time. So again, this idea of remote monitoring and capturing how patients are doing in the real world in their own setting. This is an image of one of the wearables that has been created by Dr. Malandraki, who's very famous in the swallowing world. And here in conclusion, just moving forward, I think Gerontechnology is a great solution for patients with swallowing dysfunction and particularly those who are older, because we can assess their swallowing remotely and monitor it over time in the real life setting of those older individuals without having them come so regularly to our office and requiring them, distant travels, and especially for those patients with mobility issues. But to leverage this type of technology, you really need team science, and you need to work with designers, computer scientists, and also ethicists. And then it's also a great opportunity for us to advocate for our older adults and find solutions for improving their functioning without requiring too much medical intervention in the office. And then finally, it's an opportunity for entrepreneurship. I have an image here of one of the wearable devices that has been commercialized. And I think that this is a place where young people can really be creative and unleash the potential of digital technologies and AI. So with that, we'll go to the next speaker. And that's going to be Dr. Bush.
Can you see my slides okay?
We do.
Great.
Yes.
Perfect. Thank you. Greetings, everyone. It's a pleasure to be with you. And I'm grateful for the opportunity to just talk with you about a little bit about hearing telehealth and some challenges and opportunities in an aging population. These are my disclosures. I've served as a consultant for some of the cochlear implant companies, but I don't have any conflicts of interest with this content of presentation. Our research is funded by the NIDCD through a variety of different mechanisms. And my last disclosure is that this is a picture of Eastern Kentucky, which is wild and beautiful, that I took with my own phone just a a few months ago. So rural areas like this are beautiful to visit, to hike, to take pictures, but it's a challenging environment to be able to provide health care. Many adults face a very complex, long and winding road as it relates to entry into and progression through hearing healthcare. This is an image that comes from a article from Ashley Nassiri and Matt Carlson regarding the process that patients may go through from an initial self-realization that they may have a problem with their hearing, perhaps through the progression of diagnostic care, hearing aid amplification, if they're a candidate, perhaps through cochlear implantation and the programming and the care that's involved in receiving and maintaining and using a cochlear implant. And it's a really challenging, complex road that may take patients in many different geographic directions, and can be difficult to process that emotionally as well as audiologically. There's some really challenging areas and some great areas for opportunity. That's where the entry and the transitions of care provide a lot of opportunities as it relates to research and public health initiatives. That there's many individuals that may not be aware, or may be aware but haven't done anything about hearing loss, and they haven't really entered into hearing healthcare. And that represents that top oval on the left, where patients may not actually talk about it with their primary care provider. Furthermore, patients that may have hearing aids that may not be well fit, or if their hearing loss is beyond a certain degree, they may indeed be a candidate for cochlear implants. And this bottom right oval demonstrates kind of this other area, this transition of care, where it's sort of a leaky pipe, if you will, that a lot of patients never pursue and further progress along the road into cochlear implant candidacy and cochlear implantation. And those are two specific areas of opportunity that I'm going to touch on tonight through some pragmatic research that we're involved in. One of the challenges that we face in adult hearing healthcare is that, we certainly have many biologic influences and lots of different risk factors for hearing loss, but we also have many social determinant of health domains that impact the access and utilization of care. I practice in the Commonwealth of Kentucky, kind of shown in the middle of the map on the right, and the yellow star is where Lexington's located. And we're right at the precipice of the Appalachian region of the United States, which is an area that stretches from New York all the way down to Mississippi and contains about 8% of the US population. Appalachia is known for pervasive health inequities. And this socioeconomic depression map demonstrates those counties that are the most socioeconomically depressed. And you'll see that the eastern third of the state of Kentucky on the map is some of the most socioeconomically depressed counties in Appalachia. Furthermore, in the United States, for that matter, too. So this creates an incredibly challenging backdrop for the delivery of hearing healthcare. What we find is that overall in adults, we've got about a 40% of the population that have hearing loss, but only about 20% of adults have had an audiogram within the last 5 years. And then, this is where vulnerable populations that may be in rural communities or in socioeconomically depressed counties may have a higher incidence of hearing loss, but yet may have longer commutes and lower education and unfavorable insurance. And so what happens is that inequities in some of these populations amplify this mismatch of a high prevalence of disease and low utilization of care. Some of the research that we've done have just been describing some of the differences in the timing of hearing healthcare for adults that may live in rural communities versus urban communities. And looking at a hearing aid population, adults from the time point that they have they're self-aware of a hearing loss problem to the time that they get a hearing aid is about 26 years for rural adults versus about 19 years for urban adults. And hearing loss has served as a barrier to further education or educational attainment in adults that use hearing aids in rural communities. If you look at those that have cochlear implants, there's a similar pattern, about 36-year journey from the timing of onset of hearing loss to the timing of implantation, compared with about 29 years in an urban population. And those rural adults with hearing loss who have had cochlear implants 40% of them had a hearing-related loss of a job or job opportunity, compared with about 12% in an urban population. What I'm going to talk to you about, first of all, is a study that's currently ongoing through an R21, R33 mechanism from the NIDCD that's focused on hearing healthcare assessments. And this is a study called HARC, Hearing Healthcare Assessment in Rural Communities. This study has two components to it: the R21 phase, which is an exploratory phase, in which, using a mixed methodology, we've recruited adults that are within rural health clinics. This is a healthcare system that's throughout the United States that provides frontline safety net care for rural communities and have some special carve-outs with CMS to be able to provide some unique services. And this is an area that is a really important partnership and an opportunity to consider this health system as a way to be able to partner from a research standpoint and a subspecialty standpoint to engage in the entry into hearing healthcare. And so what we've done is recruited adults within these clinics as well as providers to help us understand the utilization, resources, and priorities as it relates to hearing, and then also to provide a hearing screen through a Mimi Health app within the primary care setting, as well as an HHIE hearing handicap index assessment as a questionnaire. We want to use that information to help us inform an intervention phase, which we're currently in now, in which we're using a layperson patient navigator program to try to promote hearing healthcare for adults that are outside of hearing healthcare to be able to enter into and receive a diagnostic audiogram. This is some of our findings that it's unpublished at this point. We submitted for publication in the near future from our R21 phase. But what we found across these 10 different rural health clinics in the state of Kentucky, that are mostly in Eastern Kentucky, we recruited 388 individuals with an average age of 51. And only 3% of individuals had an audiogram within the last year, and only 13% of individuals had had an audiogram within the last 5 years. Furthermore, using our hearing assessment and hearing screening, essentially 70% of these adults have an incidence of hearing loss, which, considering this average age, this is significantly higher than the average population, compared with about 30%, or 30% not having hearing loss within this population. So this study is important in that it is helping us to use some mobile technology. This information through Mimi Health we decided to use this because of COVID. A lot of those of us that were trying to figure out how to evaluate hearing of our patients remotely during the COVID era were using the Mimi Hearing app, having patients share the results, upload those, communicate with their providers regarding that. And it's a relatively easy test to administer. And apps like this, though, can be really helpful within a primary care setting because it can give some clarity. It can be done while a patient's in a waiting room, before or after an encounter with a clinician. The next thing I want to talk to you about is just about how can we provide more complex remote evaluations for patients. This is, considering that second oval on that long and winding road map that I had shown you of patients that may have hearing aids that may be poorly fit or may be inappropriate for, and they may need to consider cochlear implant. But how can we provide evaluations when the patients are at a significant distance away? We designed and developed a telemedicine cart to be able to assess patients with more complex evaluations. And this is a preliminary study that described some work, just some feasibility about this type of a setup using 13 participants, 8 normal hearing individuals, 5 individuals with moderate to profound hearing loss. The reason we wanted to assess normal and those with hearing loss is we want to evaluate kind of a before and after for the same patient within subject control in a normal cochlear implant evaluation setting, and then an evaluation using this telemedicine cart setup in which the audiologist was in a remote location. We assessed AZ Bio and CNC testing in a soundproof booth with +5 signal-to-noise ratio. And those that had scores within 5 percentage points from the in-person AZBio to the telemedicine version of the AZBio were considered equivalent. This is the setup. The cost when we first set this up about a decade ago was pretty significant. Polycom 500, Otosphere, a lot of this technology goes out of date and is obsolete just after you purchase it. But this is just an example of how a setup could be created to be able to enable a complex evaluation for a cochlear implant candidacy. This is the setup that we use. We were placed patients in a soundproof booth in a remote clinic location that we had about 100 miles away from the main campus here in Lexington. And you can see on the screen on the left, there's an audiologist who can communicate with the patient. The patient can see themselves, and there's a computer screen, and a tech would be present to be able to help set the patient up and to be able to provide the testing scenario. What we found in this study is that 92% of the overall participants had equivalent test results on AZBio, and about 80% in those that had more severe to profound hearing loss. And then at the CNC, there was about 77% equivalent, 10 out of the 13 total. And then of those with severe to profound, it was only about 40%. And what it did is it underestimated their performance. Patients actually performed much better on the CNC testing, nearly, much higher than they would with the telemedicine version versus the in-person. So these are some complex problems to try to solve and try to address, but these are just some examples of how we can use some technological equipment and software and opportunities to be able to address vulnerable populations. Thanks for your time.
Thank you so much, Dr. Bush. This was amazing. Next, we have Dr. Neel Bhatt.
All right, thank you all. Hopefully you can hear me okay. Yeah, that was amazing presentation, and switching gears a little bit back into the larynx, hoping to share our experience with using mobile technology to hopefully improve the care, diagnosis, evaluation of age-related vocal atrophy. So, as laryngologists, we look at larynx, we look at vocal folds, and we assess many things, including closure, pliability, mucosa. And while young individuals can have larynx that may look like this, it's starkly different from someone who has age-related vocal atrophy. And we can clearly see the differences, that the mucosa doesn't vibrate as well. There's atrophy of the vocal folds, kind of a bowed appearance, incomplete glottal closure. But precisely what are those visual differences that lead to this difference in diagnosis is unfortunately quite qualitative, subjective, and can lead to some difficulties with study and clinical care. And so when we look left and right, the two images, you can clearly see there's a difference. But what are those differences? And why is it a problem that this diagnosis is unfortunately qualitative and sometimes subjective? And I think there's several reasons. Number one, with clinical care, clinician A in a different institution may rate age-related vocal atrophy as being quite mild, whereas someone else could look at the same image and think it's more moderate or severe. In other situations, for example, in studies, inclusion of patients with age-related vocal atrophy, which is a visual diagnosis, for many of the studies in our field, the inclusion is purely subjective. So if clinicians think that vocal atrophy is there, a lot of times these patients are recruited for these studies. And I think the third problem with the qualitative assessment is that when someone undergoes a treatment, whether it's part of a study or just in routine clinical care, judging success is often really predicated on making sure that there is true changes at the larynx. But a lot of times with subjective measures or patient-reported outcome measures, this is not often done either clinically or in the research setting. So endoscopic measures of vocal atrophy have been around for a long time. Two measures that I'm highlighting: bowing index, which is a quantification of how bowed the vocal folds are, looking at the bowed distance normalized to the length of the vocal folds. Normalized glottal gap area is another measure that has been used for quite a while, mostly in the research setting. And so we can go back decades to look at this literature. But unfortunately, it has not really permeated clinical care, and in some ways hasn't really caught on in a research setting. Part of our lab's work has been to bolster the importance of these endoscopic measures. And some of our studies to add to the growing literature is that we found, compared to patients with mild dysphonia, compared those to more severe forms of dysphonia, bowing index increases, normalized glottal gap area increases. And in other studies, we've looked at patients with age-related vocal atrophy and getting thyroplasty, which adds bulk to the vocal folds. We can see that voice improves, so does the bowing index, so does the normalized glottal gap area, suggesting that these are good proxy measures for treatment success. The real problem with this, though, even though we're very high on these measures, is that it's really cumbersome. You need to get a still image from the endoscopy tower, almost manual calculation of these things, which led to this idea of, why don't we put something on the strobe machine or the software that's running it? And that was the original idea. Conversations with Dr. Johns, I think, is on. We came up with this idea of, why not use mobile technology to measure this in a more streamlined fashion? So that led to the development of this very basic first iteration called Glottic, which in clinic setting, you can take a photo or upload a picture of vocal folds in an abducted position. And then at this point, you can move to identify specific landmarks on the larynx. And so clinicians can do this in real time in the point of care setting in front of the patient to quantify the bowing index, for example, in this case. And so once those are set, it lets you know what the bowing index is. And then different labels can be placed, including age, BMI, sex, patient-reported outcome measures, CAPE-V, which is a measure, auditory perceptual measure of voice. And the most exciting thing about this is that it can be shared. So we are getting this de-identified anonymous data. Time to calculation is much quicker with the app compared to manual, and there seems to be good correlation between the two. We are looking at the inter-rater and intra-rater reliability, which appears to be good. But what's really exciting is that there appears to be a clear link between what the app is showing us and what clinicians' expert opinion on no bowing, mild bowing, moderate bowing, and severe bowing. And so these types of connections suggest that these quantitative values are not purely out of left field, that they line up with what clinicians are seeing. Like I said, the really great thing about this app is that clinicians can use it all over the world. And, in the first 9 months that we've had this released on the Apple Store, we've had about more than 1,000 data points. This is just an aggregate of where patients are in terms of vocal fold, left vocal fold, right vocal fold, and you can see this distribution of data points. Each little dot represents a single patient. And some of our early data, we're tracking how does the bowing index, for example, change by age. But really, this is early work, and we're hoping to get people like you help to try to keep making this better. We want the data to be shareable so that everyone can look at these types of data and analyze it themselves. And my hope is that something like a bone density scan, for example, where based on a patient's male, female age, what is the expected bone density. Perhaps with this kind of mobile technology, a lot of people using it, we can have a lot of data to know that at a certain age, what is the first standard deviation away in terms of the mean Boeing index, for example. And so, yeah, excited about this ongoing work, and hopefully some good ideas, and people can share this type of work and analyze themselves. So thank you.
Thank you so much, Dr. Bhatt. This was also incredible. It's exciting to see how much innovation is happening in this space of gerontechnology and otolaryngology. So now I have some questions for the panelists, excluding myself. So we talked a lot about access and also standardizing or assessments in otolaryngology through digital technologies. What other aspects of otolaryngology do you think can be improved with these digital tools, especially when it comes to the care of the older adults?
I can start. Yeah, I think that, from my own experience with using mobile device technology, I do think that there are some trade-offs, and that, for example, with some of the data that we shared, we don't know precisely the quality of a lot of this data, but our hope is that with just the sheer amount of data, that some of the imperfections kind of get washed away somewhat. And that's, I think, the real kind of joy of this type of work, is that whereas previous studies have had maybe an N of 20, 30 patients, we're hopefully able to get thousands and thousands of patients to make better estimates of things. So I think, to answer your question, I think the access to lots of different patients, allowing that to be shared, I think is a really exciting use of this type of technology.
Yeah, and especially with video laryngoscopy, we all have a different setting and different light source, etc. So certainly having diversity of images can be very helpful. That's great. Dr. Bush, did you have any thoughts on that?
Yeah, sure. Thanks for the question. I think something we see in the hearing loss world that can be a benefit for the aging population is remote cochlear implant programming. Several of the cochlear implant companies have developed apps and platforms for patients to directly communicate with their audiologist, for their audiologist to remotely to connect with the device, make some changes, and keeping the patient at home comfortably, giving the patient that convenience factor of just being able to communicate. There's workforce challenges for audiologists to consistently be able to do that, but if they can do that kind of in between appointments and be able to maximize their schedule otherwise, and unfortunately, those that travel a great distance, they if they no show, and sometimes their communication ahead of time is an issue. So we do deal with some adherence problems with those that may be at a greater distance. I think another interesting opportunity that we're seeing as we are now developing and implementing our patient navigation program to try to influence public health initiatives for hearing screening or hearing healthcare, is that we can remotely connect with patients and provide them social support. We can help build their self-efficacy. So there are opportunities to try to improve adherence to treatment plans, such as, we've referred you to an audiologist to get a hearing aid. We've referred you to a cochlear implant specialist just to get an evaluation, to talk through that, to work through that. And, we as specialists are focused on, the complexity of the care, but we often spend very little time in the social work that's needed to kind of build confidence and help those patients during transitions of care. We often think about social work in some of the settings of our complex head and neck cancer patients who are definitely in need of that, but we can learn from the use of navigation and other support systems and systems of care to be able to kind of help patients in every aspect of otolaryngology. And I think remote connection to social support makes a lot of sense.
Yeah, I love your answer, Dr. Bush. I think you know, your programs are incredible, and you got a lot of government funding. Now, thinking about potentially other settings where those support are not available, how do you see these programs? How do you see them become sustainable? How can we fund these programs and make them really, you know, the standard?
Yeah, it's a great question, which I don't have a definite answer for. I think, you know, it's going to take team science, as you described. It's going to take team building and collaboration. It will certainly take industry partners to, you know, make sure that the equipment, the treatment options that we have are compatible with remote connections and remote adjustments. And that certainly is going on in the cochlear implant world. But I think that's where it will be sustainable. Now, another element of sustainability is to be able to provide, you know, have billable hours for whether that would be a social worker or for a community health worker to be able to provide some remote connection and counseling with a patient regarding hearing loss or perhaps another condition in which an otolaryngologist may be providing some support in. That is one of the reasons that we're partnering with rural health clinics, because they do provide community health worker delivered care, and that is sustainable because it's billable. So we have to prove that it's feasible. We have to prove that it's culturally acceptable and relevant before we would then, you know, go on in the cost effectiveness world. But those are my thoughts.
Great. And a question for Dr. Bhatt. You know, I'm a laryngologist, so I'm a little biased in, you know, in being excited about your project. I think in laryngology, we use a lot of subjective assessment of laryngoscopy, stroboscopy. How will you convince your colleagues to use your tool? What is your pathway from your innovation to actually implementing it?
That's a really good question. And I think there's natural hesitation with changing the way things are assessed, especially distilling things down to a single number. As I've thought about it, I feel like the path forward is to be sort of complementary with subjective measures. And I think there's still a place for it. You know, even though we're trying to create connections between quantitative evaluations and subjective assessments, I do think that the subjective assessment may be able to synthesize more data in a way that a single picture can't yet. And you know, and that's an area of ongoing work, is that it would be great if we could distill it down to one number or one measurement or something like that. But I think that to convince people that this is helpful is that really emphasizing the fact that the subjective assessment, at least for now, still has a really vital role, and it may be better, but we are trying to hopefully have complementary data that has value together. I hope that answered your question.
Yeah, no, it does. That's a great answer. So now I'm gonna go back to Dr. Bush, but the question is really for both of you. So we'll first do Dr. Bush, then Dr. Bhatt. I'm just curious, what is your personal story? How did you become interested in gerontechnology? Do you have any advice for for attendees here on how to get involved or how to come up with a team like the ones you've built?
Yeah, that's a great question. My relationship with technology and public health and health disparities has been kind of a love-hate relationship. So when I was a fellow, neurotology fellow, I had been doing bench research, vestibular schwannomas, meningiomas, kind of NF2 related tumors and tumor tumor molecular biology and drug development. And I was thinking about, okay, what am I going to do when I grow up? And, you know, what kind of grant am I going to write? in the meantime, I was at Ohio State, and we saw patients from southeastern Ohio and a very needy area, delayed in diagnosis, where they were kids or adults, delayed in treatment, late to get cochlear implants, usually presented with severe, like profound hearing loss, and not just hearing loss of less severe forms when they were ready to get a cochlear implant. And it was really just kind of a personal issue. Like we need to like address some of these challenges. And I thought, okay, here came a grant opportunity, grant announcement between the University of Kentucky and Ohio State, collaborative grant. And I was going back to my alma mater to practice. And I thought, this is great. I'll certainly get this grant. And I wrote a grant about using basically some technology to do remote ABRs on children, in rural Eastern Kentucky. And I arrived back on campus. The grant got reviewed. I did not get the grant. And I was so irritated. I was like, what are you, I can't believe this. And, some of the critiques that I read about in the grant made a whole lot of sense. It was kind of like, do you even understand your population? Do you even understand, the needs that are there, the differences in these rural and urban communities? And you just wanted to come in and provide a telefix-it. And, they were totally right. So at first I'm thinking like, hey, technology is the answer. Let's fix it with technology. Let's just, give them an app, give them a device, put in this, this monstrosity, this telemedicine card that I showed you on the slide. And the reality is that I needed to take like 3 or 4 steps back and say, all right, I need to understand all of the complexities of not only the epidemiology of the disease, the impact of the disease in these communities, and the inequities and the disparities in care. And then I need to understand, what is this population interested in? What do they think might help? And what might they find culturally acceptable? For some that are in vulnerable communities, especially some older adults, may feel that technology is not the same, and a telemedicine visit may not be the same as an in-person visit. They just don't culturally believe that. So I've had to kind of like, get it out of my system. Like, okay, I'm not going to do tele anything. And then I'm going to come back to it and consider then, okay, how can we now use some technology and weave this in and integrate this with the other things that we do? So my advice, I'm sorry for that long story, but you asked. So my advice is like, don't rush in and say, I've got the telefix-it. I've got the widget, the app, I got the device. It's going to fix everybody's problems. Like, you've got to understand the people that you're studying, the people that you're caring for, before you, just plop that, on their doorstep through FedEx.
Yeah, no, that's a great answer. And in fact, I think a lot of the innovation nowadays skips a lot of the implementation science, but that's so important. You need to be thinking about your stakeholders, understanding them, really empathize with them, so that you can really create technology that is adapted to them. So that was a great answer. Dr. Bhatt, I'd be curious about your story.
Yeah, no, that's great. I'm relatively new in the field laryngology, and for me, and that's, Dr. Rameau, I really appreciate all your work, because I feel like philosophically aligned in that we have so much cool technology in laryngology, from scopes to acoustics and aerodynamics, but the final piece in the analysis oftentimes falls short. And I think it's just legacy and history of how we assess treatment and diagnosis. And so I think my motivation really came from some frustration with how we measure things, how we judge success when we're doing these studies, how to measure whether something has changed, as opposed to just be completely reliant on patient opinion, patient perspective. And I think it is interesting how something so dry like outcome measures can really be eye-opening, and you can almost reverse engineer treatments because you have a better way to measure. And so for me, it's a simple thing, but I think strong measuring capabilities and using technology so that everyone can do it, I think, are the primary reasons for pushing it forward.
Great. That's fantastic. And I'll just chime in a second for my own path, which is that I have a background actually in philosophy and the social sciences. And for me, it's hard not to think about the big picture. And sometimes I find that in ENT, we can be a little bit too focused on our own specialty and our own technologies. But the reality is that the world around us is moving very quickly right now. And there are ways for us to really make a lot of the complex and technology heavy aspect of our field more accessible. And so I think it's a very exciting time, but we cannot forget the user and really thinking about the needs of our patients and their specific settings, but also how to make things economically sustainable, not just for the healthcare system, but also for patients is very important. So a lot of really cool projects, I think, in the horizon. And hopefully our patients are going to benefit too. With that, we have 5 minutes left for questions from the audience. So don't be shy. It's a small group, so feel free to put your video on and ask us questions. Anyone? Otherwise, I'll keep on asking questions.
I have a question, actually. Alex Chern, Neurology Fellow at Johns Hopkins here. Dr. Bush, thank you for the wonderful talk. It's really great work you're doing to expand hearing health care to rural and underserved communities. I think you made a lot of great points for trainees and junior faculty looking to get into this type of research about how to approach implementing proposed Chern technology solutions and understanding your key stakeholders. I was wondering, for your projects, what do you think the actual utilization of the rural health clinics themselves are amongst rural adults? Because I think, I wonder if there are rural adults who are not even able to utilize these clinics. And I was curious, if these community healthcare workers are, and what they're doing to help these individuals and who probably were not interviewed and participated in your study.
Yeah, Alex, thanks for that question. Good point. When you're dealing with vulnerable populations, whether that would be locally in complex inner city environments or in rural communities, or if it's low to middle income countries where there's a disconnect between care and the community. Individuals that can work, that can eat, that can drink, that aren't in debilitating pain often carry on through many health conditions without seeking care. And so there's an avoidance sometimes of care. And so there's certainly a rural population that don't even access these safety nets. There's a lot of local trust that's built up there. And even if they access it infrequently, they sort of look at these providers in those communities, at those particular types of clinics, as pillars in their community, sort of someone that they look up to for knowledge and for wisdom for anything that might be related to care. And so, and word travels quickly in these communities. So I think as rural health clinics like this, which, not every clinic that's in a rural community is a rural health clinic. You've actually got to go through a process to obtain that distinction for billing purposes with CMS. However, those that, and we use that as a model to kind of study that across the US, but I think when it comes to some of these communities, if you can build a connection for research purposes and an interface between specialty care and the rural care, it can create a better pathway for exchange of information and recruitment of participants. So again, it's an important community or important health system and a model in primary care to be able to work with.
Thank you.
We have time for maybe one quick question. There's one in the chat maybe, or no questions in the chat. So thank you so much. Thank you. This was a really wonderful panel. I think we all learned a lot, and it's very, very exciting to learn about coming innovations and current implementation efforts. So thanks everybody. Thanks to our panelists. I also want to thanks ASGO as well as Dr. Briggs for supporting this, this webinar, and we hope to see you soon for next webinar. Thank you. Bye.
And everybody, I'd like to encourage you all to join the American Society of Geriatric Otolaryngology. It's free, and we host several free webinars and talks associated with the other societies in our specialty at meetings throughout the year. So I included the link that you can sign up on. It's a very easy sign up. So again, thank you all for joining, and we welcome you to our society. Thank you.